So, folks, important that we share my active involvement in areas both of clinical research and systems improvement related to hospital-acquired infections. On slide 2, my involvement is both through funded research at the NIH, Department of Defense, and with a startup biotech company in our near vicinity, Accelerate. I've recently co-chaired the Surviving Sepsis Campaign guidelines that were published last week, and we'll be referring to those as we go through. You've had an opportunity to see the CME objectives, and then on slide 4, we will just focus on what we want to get through today. So the primary opportunity here as a HEN is to look at how we can take our shared information and knowledge around hospital-acquired infections in general, but specifically around the disease state of infections and complications on mechanical ventilation. And I will be refocusing our nomenclature around a new concept, the IVAC. These are infectious ventilator-associated complications, as a broader epidemiologic way to think about ventilator-associated events that include pneumonia, but we believe are easier for us to track, capture, and report, and then provide 3 strategies that we think may be helpful as a collective in moving our individual sites to enhanced care and delivery. So moving to slide 5, just a moment on the disease state, and whereas I have no doubt that every participant on this call has either seen or been party to the care of a patient with ventilator-associated pneumonia, what we have to appreciate is just what kind of impact it has on our care provision, particularly in ICUs, and most importantly in the post-ICU course for patients who survive this illness. We believe it's the second most common hospital-acquired infection. Certainly, it constitutes a very significant disease, cost, and morbidity burden. And then, as you'll note here, the mortality has been reported variably between 13 and 55%. And this really depends on whether we consider so-called attributable mortality, directly attributable mortality, or mortality in patients who incidentally develop VAP. And so there's no question that it does confer additional both morbidity, mortality, and cost. And the big challenge in this area is it remains very difficult to diagnose in a conclusive fashion. So let's look at this patient together. And on slide 6, you'll see a patient from our ICU. Here, mechanically ventilated, lots of lines and tubes, which are the linear shadows across the chest X-ray. And then instead of normal air space containing lungs, which are predominantly black, what we'll appreciate on this X-ray is the extensive amount of airspace and peripleural fluid collections that cause baseline opacity. And so this would be a very typical patient in an ICU who might then develop fever or change in the color of the sputum or white count elevation, or in fact have a new blood culture positive, in whom we are going to try to make the determination that on top of all of their pulmonary disease and pleural effusions has a new pneumonia. And this particular diagnostic challenge has bedeviled their field for years, and frankly has, in my opinion, delayed our ability to actually enhance the delivery of care and prevention efforts for our patients at risk. So if we look at slide 7, we can now contextualize just what's going on in that patient in a more schematic fashion. And what you'll note is 10 important domains that contribute to the pathogenesis of ventilator-associated pneumonia. We'll talk about the bugs in just a minute, but we need to look at our patients specifically and appreciate that just through the process of being recumbent for many hours a day, 8 to 24 hours a day, depending on how well the patient is, having altered flora of the oropharynx with shifts in the microbiome, the natural host flora of that environment, aspiration of gastric contents, mechanical changes to the host defense, the buildup, number 4, of biofilm, frequently of gram-negatives, including Pseudomonas, around the plastic cuff and the polyurethane cuff of the endotracheal tube, alteration in host immunity because of underlying illness and obviously immunosuppression, the effects of stress ulcer prophylaxis, dental plaque, and perturbations in nutritional state that can confer increased risk or decreased risk for infection. And then obviously the comorbidity process, and particularly in many patients who have structural lung disease, cardiovascular disease, diabetes, obesity, many of these will alter significantly the microenvironment of the upper airway and potentially confer increased risk for ventilator-associated pneumonia. So on slide 8, we could then put that now recumbent patient into context and appreciate that at several levels, pooling of contaminated secretions with rapid overgrowth of pathogens and dispersal of the biofilm with ventilation, that's the arrow to the bottom right, with each cyclic tidal breath, can rapidly spread biofilm that's either contaminated or frankly infected and result in distal airway infection. And this, we believe, is the most common pathway for infection, is via the cannulated endotracheal airway. But of course, we also know that infections in the lung can seed hematogenously, and certainly the more atypical infections may actually be hematogenously spread. On slide 9, we now drill right down to the culprit, and in this endotracheal tube in cross-section, which has been basically sliced open after removal from a patient, you'll get a real sense of what biofilm looks like. It's that crud lining that basically reduces the surface area and transverse diameter of that tube and is essentially a zoo of microbiota pathogens literally waiting to be cyclically dispersed in respirable particles into the distal airway. We believe that this is extremely common, and of course I'm certain in your practice you will have taken a minute to see one of these. I note a comment there from Mana Haythorn, who says we don't see the slides, so let's just take a moment. Amy, could you confirm that our participants are able to see the slides, please?
Yes.
Okay. So could that participant then just please type in a comment and confirm that you now can see the slides, and I will continue. Okay. On slide 10, we need to then take a step up to the portal of entry.
Dr. Douglas?
Yes.
We are having a little bit of difficulty. Just a moment. I'm sorry to interrupt.
Of course. I will pause a moment for sure.
Are we still having difficulty seeing? On my end, I can see okay. Mano, can you confirm?
Hello, Amy. Yes, the slides are not advancing as to the panel or to the attendees, so they're only showing the first slide at this point. I was able to advance them on my end as I am the host, but I believe you might want to go, okay, so we do have advancement now.
Are we able to see now?
Yes, I believe that now we should be able to see the advancement happening.
Okay.
And yes, I am getting confirmation from the attendees that we are able to see the slides.
All right.
All right.
Let's then just slip back to slide 7 if we could.
Certainly.
Okay. So folks, just to bring everybody up to speed, and I do apologize, thanks for highlighting that challenge. What we're focusing on now are the host components, the patient-specific components that contribute to risk for pneumonia. And what we had highlighted on slide 7 was a composite of all of those phenomena. And we were just highlighting then in more detail some of the most specific. So if we advance now to slide 10, what we here have is the portal of entry in a very graphic sense, the oropharyngeal cavity of a patient with very serious periodontal and other gum disease. And although this is pretty disgusting, and it's not a horse, it's a person, so the question then is just how much of a risk is this? And you'll appreciate that missing tooth there might well have been displaced during a recent procedure or may have been absent previously. And certainly the risk for bacterial infection is very high for many of these patients that we end up seeing. So then let's look on slide 11 at what the course of illness is. If a patient does present to, let's say, the emergency room, is intubated emergently, it's clear that the risk for pneumonia in the first couple of days is really related to pathogens from the community, so-called community-acquired pneumonia. But very rapidly, there is an increase in the incidence early on of infections that are potentially multi-drug resistant. So what we'll appreciate is that after the first 2 days, that's the box at the bottom right there, the risk of strep pneumonia, Haemophilus, and methicillin-resistant Staph aureus begins to wane, the top line, and that by the 6th to 10th day, the incidence of multi-drug resistant pathogens, both from colonizers and pathogens, including enteric gram-negatives, increases quite substantially. And then by late course, about days 14 to 21, particularly in immunosuppressed patients, both the hazard decreases overall, but for patients who do develop infection, the risk for serious multi-drug resistant pathogens increased very, very dramatically. So we are going to focus most of our efforts around the second week of care for patients in the ICU. This is really where we believe that the biggest impact from our interventions and efforts can be achieved. And these three big steps that we're going to suggest are part of our HEN initiative really could be maximally focused in that time. So perhaps as a center, as you're looking about across the course of care, when's the best time for me to be doing these things, we would argue the second week of care is the most important. So let's go back to another patient to highlight the particular challenge. On slide 12, this is a patient with a tracheotomy. The patient has quite serious emphysema, structural lung disease, also has airspace process, possibly pulmonary edema. And what this really does reiterate is with that patient's nasogastric tube, the tracheotomy, now obviously into the late phase of critical illness, perhaps a day 21 patient, is that the risk does not decrease and the opportunity for misdiagnosis is certainly as dramatic as the patient I showed you before. On page 13, then, we should then review how have we done it to date, how have we made this diagnosis. And in its most simple form, this is made using the so-called 2-1-2 approach, the CDC and NHSN method. And what this historically has required was evidence of a new radiographic infiltrate for at least 2 consecutive days, that's the first 2, one of the following parameters, either fever or perturbation in white counts, leukocytosis or leukopenia, and obviously leukopenia is a very grave and concerning thing. And then the second 2 is to have at least 2 additional features, sputum change, cough or dyspnea, alterations in auscultated breath sounds, and then worsening in gas exchange. And so this 2-1-2 approach has been the consensus standard to date, which unfortunately has performed rather poorly. So let's just break it down. In the patient I showed you a minute ago, you could see that with the underlying structural lung disease, it could be very difficult to determine whether in fact there is new progressive or persistent infiltrate on the X-ray, just because the underlying structural lung disease confounds that interpretation. We know that fever and white count, while sensitive, are not particularly specific for new infection. The SIRS criteria discussion has been endlessly debated. And then when it comes to the additional features, it turns out that worsening gas exchange is certainly a very useful predictor, but the others, particularly change in sputum, can be very nonspecific. And we are certainly aware that purulence in the sputum is by no means a necessary indicator of infection. In fact, purulent sputum, neutrophil predominant sputum is common in other forms of lung inflammation and does not necessarily suggest a bacterial infection. So this has been the framework and perhaps the challenge of where we've been up to. And I've just summarized those for you on the next slide, on slide 14, and reiterate that most patients that we label with VAP in fact, do not have pneumonia necessarily as the etiology for their disorder. Now, this has been verified in several studies, but in a good summary paper, Mike Klompus in JAMA in 2007 highlighted there as a worthwhile reference. So what has then emerged is an effort to enhance the way that we make the diagnosis, and to do that has been efforts to use minimally or non-invasive strategies to do that. And what has been suggested is that the predictions value of these clinical signs can be enhanced when combined with a clinical pulmonary infection score risk predicting tool. And what this does, it incorporates some of the features that we highlighted on the previous slide from the 2-1-2 method, but it includes other parameters of organ dysfunction and illness. And when combined when used either alone or in combination with the VAP criteria, may improve the clinical diagnostic sensitivity and specificity quite significantly. You'll see that sensitivities in the mid-80s and specificities as high as 90% have been reported for a CPI-modified risk prediction. Now, the challenge with this is that it's not been well validated, perhaps only a few small studies. It has variable concordance in performance when compared with quantitative bacterial cultures. And frankly, it's pretty laborious to have to score patients for the purpose only of risk prediction and then consistently use and apply that at the individual patient level. No question, it's quite useful to do that at an epidemiologic and retrospective level to get a sense of overall disease burden. On slide 16, then, to highlight where we've come to, has been the historic efforts. So just advance it one more. Yeah, there we go. To integrate this approach, think about the patient at risk, consider whether they have a CPI score elevation, integrate the features of the VAP 2-1-2 bundle, and then come to the determination of whether a definitive diagnosis of VAP is present. And indeed, this has been a reporting framework that we've used, and unfortunately, there is significant discordance between this fairly sophisticated algorithm and what we apply at the bedside. Quite honestly, my group does a monthly X-ray review, and we make determinations for internal reporting about our incidence of VAP. And we might determine that in a perhaps 3-month period, we had an episode or two of VAP. And indeed, we do see patients with this disease, even though some centers don't continue to report 0 incidents. But remarkably, when we then sit down with our infectious disease colleagues who use the strict 2-1-2 method as opposed to a CPIS or clinically modified approach, we might have identified 2 patients, they may have identified 2 patients, but almost every time we sit down with them on a quarterly basis, the 2 patients that we have identified and that they have identified are not the same 2 patients. And so this really is frustrating, and it also bedevils the opportunity to improve, because if we're identifying different people with the disease, then how on earth does one actually ever make efforts to prevent it or modify outcomes? So on slide 17 is the recognition that 16% of patients diagnosed with VAP by BAL would have inappropriate withholding of antibiotics if they were simply diagnosed using clinical risk prediction. So this really ultimately highlights where we're up to. Let's skip ahead then to slide 19 and talk about what some of the gaps are. The gaps here, therefore, are that there are many clinical mimics of the disease state VAP. Most commonly, pulmonary edema, either cardiogenic or ARDS, non-cardiogenic edema, really affect the way that the chest X-ray is interpreted. Additionally, atelectasis, pulmonary infarction, nosocomial pneumonia is present prior to intubation mechanical ventilation, and then hemorrhage or systemic inflammatory response with sepsis certainly can contribute to non-cardiogenic pulmonary edema. So we have to acknowledge the lack of specificity of the diagnosis. The second observation on slide 20 is that even when combined with the CPIS, non-quantitative bacterial cultures, which essentially would be an endotracheal tube aspirate, even though advocated as being sufficient to make a diagnosis, really may be ineffective. Let's take this patient that I showed you before, day 22 on the ventilator, who's got structural lung disease and existing infiltrates. And we would have to ask ourselves, would this patient have actually been included in a study that was designed to validate the CPIS plus culture approach? And the answer almost always is these patients are excluded, these patients with underlying structural lung disease, long-term mechanical ventilation. And so we really don't know the performance characteristics of doing CPIS scoring plus tracheal aspirate culture in patients that we care for every day. So a simpler approach is needed. And then the final gap that we realize here is that we really have a clinical imperative and that there are many unfulfilled clinical needs. What we really are most focused on is avoiding delay or the use of inappropriate antibiotics. And the reason we are most interested in that is the strong positive correlation with increased mortality. The second emphasis is that indiscriminate antibiotic therapy, we clearly understand, drives multi-drug resistant strains, colonization, and horizontal transmission. And lastly is that with the presence of empiric antimicrobial therapy and more virulent strains is the risk for significant increased mortality associated with those now more virulent strains. And obviously that's an effect that extends beyond just the patient in front of you, but to the entire cohort of patients cared for in ICUs. What I've alluded to then is that trying to guide our approach using bacteriology or culturing microbiology has a long and storied history, but is certainly widely used. On slide 22 is a spectrum of approaches that has been advocated. The endotracheal aspirate or culture of secretions from the endotracheal tube is widely performed, is both sensitive but very nonspecific. And then more standardly would be selective airway sampling. And in our ICU, we've introduced, and now for the better part of a decade, used a non-bronchoscopic approach, which is a mini BAL. Essentially, and I'll show you a picture of this in a minute, is a telescoping, non-fiber optic suction catheter that facilitates distal sampling of the respiratory space, particularly distal bronchial tree and alveoli. Clearly, fiber optic bronchoscopy with direct visualization is a standard, but very cumbersome and obviously delays care if you need an expert to do that. And then, although this sounds completely amazing that anybody would think about it, is inserting a needle into the chest wall in a mechanically ventilated patient and aspirating or taking a biopsy. And indeed, there are publications in literature that advocate that. I do not, for obvious reasons. On slide 23, then, we might want to then compare the performance of those several approaches in patients with defined VAP. So we're going to assume for the sake of gold standard here that these patients actually have the disease. And we're going to look at the culture positivity in endotracheal aspirates, that's the first column, with no culture threshold for colony-forming unit density. In a semi-quantitative fashion on the same aspirate, this is endotracheal aspirate from the upper airway, at about 1 million CFU per mil, so a reasonably high cutoff. And then from bronchoalveolar lavage, so here it was performed with fiber optic bronchoscopy with a lower threshold. And what you'll note here is that a much lower percentage of actual specimens are positive as you increase the threshold for diagnostic cutoff. And these were samples taken from 53 patients in which there was simultaneous microbiological assessments in each of those. And yes, while the detection rate is much lower in BAL, what we did learn from this study is the specificity of those cultures is as important. Negatives were negatives, and the bacteria that were isolated BAL were more consistently representative of the infecting organism than from the non-selective CSA. So in summary on slide 24, endotracheal aspirates are plagued by low specificity. There's lots of tracheal colonization, the rather poor correlation with actual culturing, and it performs a little bit better with gram-negative rods than gram-positive cocci. We know that when subjected to quantitative culture, there's variable comparability of the endotracheal aspirate compared to BAL. And overall, the performance characteristics are just at the threshold of what we would suggest are acceptable. But it is an overall more cost-effective approach than any of the invasive procedures, including the mini BAL procedure that we perform. On slide 25, I just want to highlight what's involved in BAL. You're certainly aware that these are two approaches, either with fiber optic bronchoscopy or, as I suggested, the telescoping catheter approach, here illustrated in this image at the bottom right-hand corner, slide 25. This can be most readily performed by a respiratory therapist. It compares very favorably with bronchoscopic BAL with a cut point of 10,000 colony-forming units per mil. And regardless of what happens at the bedside, of course, all of the delays that occur and any of the complexities are often on the back end, by which I mean that if the lab is either slow or there's cumbersome or expensive processes required, it doesn't matter how you obtain a specimen, that the results, the culture, could be delayed or inaccurate. Nevertheless, it's been our practice to implement blind mini BAL with a telescoping catheter very successfully and with very, very low complication rates in at-risk patients who have higher CPIS scores. On slide 26, of course, we recognize that once you've made the diagnosis, now you've got to do something about it. And there is an emerging sense that however you make the diagnosis, whether it be with the BAL or the tracheal aspirate or just clinically, the variability in the way we report this disorder confounds our ability to standardly improve and reduce rates. And there are some important questions. Let's highlight them in this puzzle approach. Neil Halperin's review article from late last year highlighted some of these. And what we are really flummoxed by is our lack of a standard clinical and clinical plus bacterial definition for the disease. And what we really appreciate and must answer is whether higher rates of preventive compliance, bundle compliance, actually decrease VAP. I have no doubt in every one of your excellent institutions you are doing some or many of the components of VAP prophylaxis. We'll talk about elevation of the head to bed, oral hygiene, etc. But the big challenge is that while individual components of those bundles have been associated with improvements, it's unclear whether the entire bundle application collectively or in a synergistic fashion reduce absolute rates of the disease. What we're not certain is whether surveillance could improve or prevent the disease itself. In other words, if we were to perform BAL on patients at risk every day, even if they don't have pneumonia, would that enhance our detection or just provide increased numbers of patients who are colonized but don't have the disease? And then I think we then have to determine if actually having any VAPs reported is a failure or substandard care. I suggested to you a few minutes ago that in our ICU, we indeed do make the diagnosis of VAP and report it internally, as I'll show you in a minute. We are endlessly impressed by institutions that report a zero VAP rate and often are interested to learn just how many patients they cared for a year or whether, in fact, that number is the same number that we are reporting. Captured on slide 27 then is this confusion in this word cloud about what we're dealing with. And I took the liberty of a recent Mike Klompus review paper from Critical Care Medicine and subjected it to the wonderful online app called Wordle, W-R-D-L-E, if you've not had the opportunity. And what the benefit of this is that it does a textual analysis for you and can highlight some of the common themes in a paper. And I think what stands out above all else in the field of ventilator-associated events is the frustration with definitions, and there it stands out to you in all clarity. The big challenge, the word definition and definitions are the biggest recurring challenge in this field. And as you'll see, we don't even know what to call the disease, never mind consistently identified. Should we call them VAPs, pneumonias, events, VAEs, infectious ventilator-associated complications, IVACs, ventilator-associated tracheobronchitis, VATs, or just are these all healthcare-associated pneumonias? And does this lumping or splitting really matter? Well, I would argue that if we aren't all saying the same thing, it is endlessly frustrating and difficult for us to consistently improve on the event if we don't report and understand the same idea. On slide 28 then is the reflection on what these challenges are with benchmarking. Benchmarking consistently ignores the heterogeneity, not only in the disease state, but in the patients. we acknowledge that there is more than just a clinical rationale for these different nomenclatures. There's lots of professional jealousy and intellectual property about professional organizations taking ownership for particular diagnostic approaches or scores. And then I think ultimately what we have to ask is, does reporting actually make a difference? Our answer, I hope, will be yes, it does. So on slide 29, if you could advance to that, we see some data from Morrow, published in Chest 2006, about the effect of these variances in VAP surveillance and diagnostic criteria. So VAP was reported for a cohort of 134 consecutive patients who were at risk. These were patients who were in that post-48-hour period of mechanical ventilation. And using these different approaches, the NIS, the initial version, gave a 2% rate of VAP. Clinical diagnosis, 22%. CPI's risk prediction score, 25%. The American College of Chest Physicians scored 29%. And then the 2-1-2 approach, or the NIS-2 standard, as high as 31%. And what I think we really have to take from this is in this active application of NIS, which is pretty much what many of our centers are doing right now, applies the highest rate and also potentially emphasizes the variance between that and the clinician's diagnosis, almost 10% less frequent. This is a major challenge, and it's unlike, let's say, myocardial infarction. I think that most of us would agree in 2013 that there's very little give and take around whether a patient did or did not suffer a non-ST elevation or ST elevation MI. We have good biomarkers. We have readily identifiable pathogenesis interventions and outcomes. But in the field of hospital-acquired infection, particularly VAP, we continue to struggle. So on slide 30, where does this lead us? Well, on the one side, the pool says we need to publicly report VAP rates to catalyze improved quality of care and save lives. You've heard that mantra. It's a mantra we strongly subscribe to. But on the other side is the realist approach. The definition of VAP is ambiguous. It's very hard to implement. And oh my goodness, it's open to being gamed. And I think that the fact that any hospitals consistently report for a year 0 VAP rates might raise that as a possibility. On slide 31, then, we have to accept that VAP cannot be accurately diagnosed. Well, yes, I think that's true, but I would suggest that we need a new framework, and we should focus on prevention, possibly rather than VAP rates. That's important because on slide 32 is an evolving understanding of what the attributable risk of a VAP is. In other words, what is the root causal association between developing ventilator-associated pneumonia and actually dying because of that pneumonia, as opposed to dying of the underlying disease that brought you to the ICU, COPD exacerbation, decompensated heart failure, ARDS. Using a sophisticated statistical modeling, Bakert, in a very important article in the American Journal of Respiratory and Critical Care Medicine in 2011, performed something called a competing risk survival analysis. And essentially what this does is it looks sequentially at risk. So it doesn't take the VAP event as a single event, but it looks at all of the competitive risks over time with significant adjustments for severity and other comorbidities. And what you'll note there is that the attributable mortality, either at day 30, 4.4%, or at day 60, 5.9%, is very significantly lower than previously reported attributable mortality rates, often as high as 30 and 40% in previous studies. And so this has evoked much discussion in the literature and amongst experts who both are appreciative of the sophistication of this modeling and skeptical because it may not align completely with what we see clinically. Nevertheless, I think that what we should appreciate is that this issue of how important VAP actually is, 5% extra deaths is bad, but it's not 30%, is certainly an area that you will hear a lot more about as we debate how much time, effort, and resource to dedicate to the prevention effort. On slide 33, we highlight here the collective objective that we have from the Partnership for Patients around hospital-acquired infections, but particularly the VAP target. And this is, of course, the driver for our HEN initiative. And the outcome here is to reduce infectious-related ventilator-associated conditions, and I'm going to come back to that new diagnosis in a moment, by 40% by the end of 2013. So essentially, if you've had 4 events in your hospital over the last year, the idea would be this year to have only 2 events. Well, let's see if that's doable. And the process here was to achieve 95% or better adherence to a modified VAP bundle by the end of 2013. On slide 34, I will introduce you to an approach that we feel is worth endorsing, which is a modified approach to disease state definition. And the reason that I'm eager to endorse this approach is that it attempts to significantly address the critiques that we've had about that 2-1-2 approach or the CPIS approach. What you'll note is that this is a 3-step approach that looks at the patient's baseline state. It assumes the patient's been in the ICU for at least 2 calendar days, and it looks for changes in the oxygenation using FiO2 or PEEP, and looks for periods of baseline stability from which changes can occur. As I then suggested, changes in oxygenation are very sensitive indicators of new pulmonary infection in ventilator patients. And what we are focusing on then, in addition to baseline stability, is a period of worsening of gas exchange, either an increase in the requirement for a fraction of inspired oxygen, FiO2, or an increase in the minimum daily positive end expiratory pressure, PEEP. The combination of those 2 events would prompt the assertion that there is a new ventilator-associated condition. What this does not do is diagnose pneumonia. It does say this is a new condition that warrants consideration of an infectious cause. And if a further day, or by calendar day 3, or that there have been 2 days of stability, there's then evidence of perturbations in temperature, white count, or the need for a new antimicrobial, which is continued for 4 more calendar days. In other words, the systemic inflammatory response and new antibiotics, this would be determined as a likely infection-related ventilator-associated complication, or an IVAC. So not just a VAC, but an IVAC that then may, in fact, if you work through the algorithm, be a pneumonia. So in summary on that slide, baseline stability, worsening gas exchange, and then the need for antibiotics. On slide 35 then, just a simple justification. This has been suggested to be a much more reliable definition. It uses objective, clinically validated measures, including changes in gas exchange. It's far less likely to be influenced by variability in resources or subjectivity. It's very much more readily capturable using electronic data, so that there isn't a massive need to go and mine paper charts. And the notion is that it's going to be implemented by the National CDC NHSN Hospital Infection Network by last month, and I believe it was. And so we anticipate that this particular process outcome will be mandated for public reporting by the National Quality Forum in the near future. So like it or not, IVACs are here to stay. And what the IVAC then leads to, on slide 36, is the ability to have a more streamlined definition of a ventilator-associated pneumonia. So you've got a patient who has now got evidence of requirement for new antibiotics and fever or white counts. And then, as you'll note here, a modified 2-1-2 approach requires pulmonary signs, which are much more objective. Evidence of neutrophils on an endotracheal tube suctions, or BAL, and then the alterations in gas exchange. So this modified approach, 1 radiologic sign, at least 1 systemic sign, and at least 2 pulmonary signs in the context of an IVAC, are suggested to be a much more robust predictor. And if you look on the right-hand side, you'll see that compared to the CDC NIST criteria, the relative performance of these criteria, particularly in terms of excluding an infection, the negative predictive value 93%, is particularly encouraging. Well, how has that performed? So let's look at slide 37. This is new data published since I first gave this talk. And what this data shows is, in fact, the new criteria of ventilator-associated complications is strongly positively correlated with outcomes from an ICU stay. So if you look at the columns, the patients with a VAC and patients without a ventilator-associated complication, now these aren't IVACs, but these are VACs, what you'll note is that there is a much longer ICU and in fact hospital length of stay, 22 days versus 11. That mechanical ventilation was required for more than 10 additional days in those with the VAC. And interestingly, a small sample number, of course, there was no difference in ICU mortality or hospital mortality in this cohort. This is rather interesting and important because what this study hasn't done is validated the IVAC criteria, but simply the VAC component of that new evaluation. So I think it at least points in the right direction that this is clinically and epidemiologically associated with important proximal outcomes for patients in ICUs on ventilators. Most interestingly on slide 38 is that if a VAC was identified, there was a strong positive association with longer and greater longer mechanical ventilation and more antibiotic use, particularly for the carbapenem and quinolone group of agents. I think that that particular selection is representative of the institution where this study was performed, which is, I believe, Australia. So how do we report and deal with this? On slide 39, here's how we are going to be using the IVAC measure in our study. We will collect the numerator of new IVACs, those are infectious-related ventilator-associated complications, and they'll be obtained on all ventilated patients and those within the 48 hours post-extubation. The denominator is going to be ventilated days for patients at risk, and the number of mechanically ventilated patients each day at the same time of day, so that there's some benchmarking. And really, this is a standard rate. It is based on that IVAC definition. It's likely that we will be able to make the call about an IVAC in many institutions based on electronic charting and database analysis, changes in oxygenation, change in PEEP, change in temperature, or the selection of a new antimicrobial agent. And it will certainly reduce significantly the burden for data acquisition and reporting. So what are we going to do with this? Well, this brings us on to our efforts as a collective in the HEN. Slide 40, we're going to collaborate to implement bundles. Is this effective? Well, if you look at what goes into a bundle, of course, there are many, many components on slide 41. Individually, the large majority of these have been positively associated with reduced rates of VAP. They include surveilling frequently for VAP using the criteria we've now discussed, hand hygiene guidelines, semi-recumbent position, assessments for daily readiness to wean, that's a topic of some discussion presently, regular oral care with an antiseptic in our ICU or chlorhexidine solution, the preference over non-invasive ventilation and orotracheal intubation. For those patients that are endotracheally intubated, checking frequently the cuff pressure on the endotracheal tube and removing any condensate is strongly recommended, and then avoiding routine changes in the ventilator circuit while reducing gastric distension and excessive or inappropriate use of H2 receptor antagonists. So this would be a collection, a bundle, a multi-parameter intervention, and when looked at by Rosenthal and others, this is slide 42, in a pre-post intervention period, there was a strong negative association with the implementation of those bundles and the rate of ventilator-associated pneumonia reduced from baseline to intervention period 22 VAPs per 1,000 ventilated days to 17, which was a significant 22% reduction in event rates. The largest change in regression analysis was associated with hand hygiene. Now, certainly that's not the focus of our HENS activities, but I'm certain, like us, you find that is the consistently most difficult thing to achieve 100% compliance with. It was interesting, associated with a small increase, not significantly so, increased use of antibiotics. which obviously may in the long term have some important consequences. So in principle, these data would point to the idea that a consistent implementation of a bundled approach to VAP prevention is associated with a reduction in VAP in a time sequential fashion. So on slide 43, we're going to go through three steps, three incremental efforts that our HEN is recommending to achieve compliance with a series of process measures and reduce outcomes. The 5 items that we want to get started with are elevation of the head of bed to at least 30 degrees, regular oral care. We're not defining the number of times a day, but at least once per shift. We prefer the use of a toothbrush as well. Daily assessment for readiness to wean, including a spontaneous awakening trial and breathing trial in appropriate patients. Daily interruption or reduction in sedation using a protocol. And then the potential use of a continuous aspiration tube called a CAS tube to remove subglottic secretions. I'll show you a picture of that in a minute. Our institution has implemented CAS tubes for 7 years, and in strong association with that has been a consistent VAP rate, VAP frequency lower than 2 per 1,000 ventilated days. So the first is to elevate the head of the bed to 30 degrees. That's slide 44. And then on slide 45, the effect of that is a significant reduction in this original paper by Trakulovich in the rate of patients who develop VAP. The big secret about this paper is that they elevated the head of the bed to at least semi-recumbent or 45 degrees, which is both impractical, uncomfortable, and generally not achievable. So the consensus is that 30-degree elevation may be sufficient. That was then studied on slide 46 in a further multi-center study, and they did not reproduce the findings, but they in fact used an elevation only 22% versus 16% for supine patients. And although this is about the only other validation study out there, we would suggest that there was really no separation between those two groups to test the hypothesis. So in summary, on slide 47, the evidence is sparse for elevation of head of bed. We clearly know that supine position plus enteral feeding is a guarantee for VAP. We know it's a practical challenge to maintain the head of bed at 45 degrees, but we strongly recommend efforts to sustain the head of bed at 30 degrees. We know that that's a challenge, and I'll show you in our REACH goal in a moment a way that we have worked to improve that. On slide 48, you'll see the recommendation to perform regular oral care here with chlorhexidine in a meta-analysis published in 2007 by Chan that was associated with a 44% reduction in reported VAPs, but didn't impact on either ventilator, ICU, or hospital length of stay. On slide 49 is the recommendation for daily sedation interruption. I will draw your attention to the recent report of Mehta and others from the Canadian Critical Care Trials Group, who demonstrated that the addition of a spontaneous awakening trial, that's a daily reduction by at least of half of the infused sedative dose, was not additionally useful when a protocolized sedation protocol was used. But this study did not report the incidence of IVACs. And so although there was no reduction in overall resource utilization, it remains to be determined whether just using a protocol and not performing a daily sedation interruption, the protocol here to achieve targeted sedation, are as effective. So clearly that there's more to be told on that story. On slide 50, I will draw your attention to the data from J.P. Kress and Bill Schweikert, colleagues at the University of Chicago. There are two important landmark papers that reiterated that daily interruption of sedation, in fact, was associated with a numeric reduction in VAP cases, the third set of bars on slide 50. And this data, in our mind, at least is consistent with the notion that reductions in resource utilization with daily awakening may translate into reductions in infectious complications. I'm going to go into, in the interest of time, skip to the bottom line of this, which is page 53, and sorry, slide 53, I beg your pardon. And so that for these basic practices, the evidence base overall is robust. We know that although the level of the head of the bed less aspiration with elevation. We strongly recommend antiseptics because they decrease VAP rates. And we would recommend daily interruption of sedation based on your current practice because it's associated with reductions in ICU resource utilization, possibly mortality and VAP. And we know that that may or may not be additive to rigorously implemented sedation protocol, and so I think that at your local site you'll make a determination. On slide 54, we highlight the subglottic suction endotracheal tube. This is an endotracheal tube that is in use in some units, but remarkably, despite being a level 1A recommendation by the Infectious Disease Society of America and the ATS, is not routinely implemented in all ICUs. What you'll note here is that this tube is designed to address the accumulation and pooling of secretions at the back of the oropharynx, and it's designed to provide intermittent suction at low pressure above the endotracheal tube cuff to prevent that bacterial colonization of pooled fluid. So if you look at that endotracheal tube depicted there, you'll see that instead of one side port, the blue one, to inflate the balloon, there's a second side port, which is a suction catheter attached to an eye that is connected to a suction device in your ICU. We have implemented this as a routine approach in patients requiring or anticipate to require mechanical ventilation more than 48 hours, and as I suggest, in a circumstantial fashion, has been strongly associated with consistently low rates of VAP in our unit. On slide 55 are the summary of 5 big studies that we believe are supportive of reductions in VAP with the CAS endotracheal tube. I'm not going to go through them, but recommend that you take the necessary time as needed to look particularly at the study by Bouzard in Chester 2008. And then looking at that data in aggregate on slide 56, in a meta-analysis, CAS reduced the incidence of VAP by nearly 1/2, a relative risk reduction of 0.51, shortened ICU length of stay, and we strongly endorse this as component of a recommended bundle of care, suctioning with an endotracheal tube. On slide 57, we think that the CAS tube, the suction tube, is cost-effective, but only supplemental to proper patient positioning, and would think that that should not increase significantly your ICU costs. But on slide 58, we highlight the many costs attendant. There's some suggestion of an almost $1,800 cost savings when routinely implemented, although clearly there are some nursing and RT costs associated that weren't included in those cost assessments. Let's then step to the working harder slide on slide 60. Slide 60 highlights what we need to do to work harder. Hand hygiene, daily chlorhexidine baths. I'm certainly not going to belabor those points. They're issues that are strongly associated with outcomes that we think are improved. And what we believe that when all 6 of those components that all 7 of the components we've highlighted, the 2 getting started and the 2 working harder on slide 61 are implemented, we should be able to measure total compliance with the bundle at over 90%. And of course, that will take a bit of a stretch to get it done by the end of this year, but we're convinced that that can be done. So then finally, we want to look at these process and outcome measures. These are on slides 62 and 63. We're going to report IVAC rates as I highlighted them. We're going to measure the process measures for each of those components, so you can advance it there on slide 63. And we will report total compliance for each of your sites that are participating in the HEN. However, on slide 64 is the recognition that nobody can remember to do it all. We do know that simpler is better, but we also know that when we standardize our efforts, we can achieve better compliance. So we, on slide 65, recommend tracking and internally reporting the rates of compliance for each of your measures. An example of that on slide 66 is how we do it. We have a wall chart. There you'll see the yellow panels. I know you won't be able to see the details. Highlight each of the processes of the bundle that we are implementing. And the blue panels at the bottom of that slide are our process and outcome measures for IVACs, VAPs, head of bed compliance, etc. And that's publicly visible. In fact, all our families, all of our providers have full access to that on the open wall of our ICU, and we strongly encourage everybody to look at that data, use it to improve care, and hold us accountable. When you look at that rate, this is slide 67, these are our real data. This is data through the end of 2012. What you'll note from here is that we do continue to have an incidence of VAP, but the incidence of VAP over the years has continued to decline, and as I mentioned now, is lower than 2 events per 1,000 ventilated days through 2012. So we do feel that consistent application is what's required, but there should be no surprise if, as we apply these bundles as collective efforts, that it takes a while to get traction. So then the last component I want to highlight is the working harder aim, which is 69. And that's the effort to integrate VAP measures and checklists. And to do that, what we're suggesting on slide 70 is that you think about ways to standardize the performance of these measures to track their implementation. I think what I need to do is improve my spelling, because I see that I've misspelled improvement on that slide. I beg your pardon. I should improve that. But what you'll see on the left is our daily rounds checklist, and on our right is our nursing quality checklist. Those are 2 items that can be very helpful in achieving what's called first order change. I am going to ask you to skip to 75 here, and there are more slides than we're going to be able to go through, and reiterate that 75 is a close-up of that nursing quality checklist. And what you'll appreciate that twice a day, as our charge nurse goes around, they will look at each of these process measures with the bedside nurse to provide an additional level of oversight for compliance, and are required, as you'll see in the furthest right column, to check or not check whether those process measures are being attended. On slide 76, we obviously emphasize the importance of communication in weekly meetings. We appreciate that these efforts to achieve perfect care can be very frustrating over time, and the whole idea of sustaining efforts can be particularly challenging. Let's go to slide 78 and finally give you the challenge, or the head of the curve challenge. This is what we have done to step ahead, and we would invite you to think about joining us in a simple effort to improve care beyond the curve. We've implemented an automated head of bed elevation monitor with electronic alarms to achieve perfect care on the 30-degree head of bed process measure. Now, the reason we did this is, as you will note, is that it can be somewhat difficult to track whether patients are in fact semi-recumbent or supine. 1 minute you'll walk in the room and they're beautifully aligned, and then you'll come back and they were bathed and somebody forgot to put the head of the bed up. And a lot of the reason that is so is from an engineering perspective is that we failed to develop systems to alert the providers. On slide 79 is a summary of a manuscript published last year in Respiratory Care by my colleague Bob Wolkin, where he developed a very simple bedside adherent device that costs about $20 to put together, and allows real-time continuous reporting of the elevation level of the head of the bed linked to an audible alarm. And there you will see a little tag that we put on the side of the monitor that highlights the degree elevation, here 30 degrees, so the head of the bed is correct, and it allows for tracking in the graph below of the actual head of bed angle over a 24-hour period to ensure consistent application of the intervention. This effort was associated with a significant level of improved compliance in our ICU, and that manuscript reports the data. In summary, on slide 80, VAP, as we suggest, is a common disease difficult to diagnose, and that focusing on prevention of infectious-associated, ventilator-associated complications rather than the final diagnosis VAP is really where our HEN is most prioritizing our efforts. We think that developing rigorous definitions for implementing and measuring our efforts are essential, and then using real-time audits with public internal reporting, like that wall chart that I showed you, is one step that we think will get us there. On slide 81, we think that we can do well collectively if we implement the 3 steps for IVAC reporting. We need to track and internally report rates, integrate prevention and surveillance into checklists, and then if you'd like to step ahead of the curve with us by implementing automated head of bed elevation monitors, we would be delighted to share some of our learnings in that regard. On slide 82, I must acknowledge and thank my collaborators on our HEN. Our lead is Connie Price with Amy Irwin, who's our coordinator for our local HEN implementation, and then our outstanding critical care team here at Denver Health, Bob Wolkin, our lead therapist, Jan Smith, our nurse educator, and Katie Overdyer, who's our lead research coordinator. I look forward to taking a couple of questions, perhaps through the text box or by open call. And thank you for joining me in this discussion.
Thank you, Dr. Douglas. We do have one question that's come in through the chat box. I'll read it directly. It says, I have a question related to HEN measures of VAP and IVAC. Our original goal has been 40% reduction in VAP, but introduction of the IVAC measures raises the question on how to track progress and what the expectation is for reporting historical and current performance.
Perfect. So yes, you highlight a real challenge. However, the IVAC definition has not changed from the first specification for our intermountain hen. It has consistently been going for the IVAC, but you're right, in retrospect, it could be challenging to do retrospective comparisons. However, the core components of this, other than the PEEP level, are data that would have been readily available for all of your previous assessments for the CDC NIST VAP criteria. So I think that the addition of PEEP or increases or changes in PEEP to make that diagnosis are one that may require some retrospective data analysis if we want to collect the retrospective data. However, the bundle process measures should be essentially unchanged from things that you may have been collecting before. Now, I do acknowledge that the way many have done the head of bed reporting is to do twice daily checks. What we have shown, and in fact it's in that same manuscript in respiratory therapy, is that point-of-care intermittent checks ahead of elevation very significantly overestimate the actual compliance when compared with real-time head-of-bed monitoring. And so I think that we shouldn't kid ourselves that regardless of whether we use newer measures or the older measures, the way we measure and the way we report is really the core here. So in summary, I don't think things are that much changed from what we've done previously. I think that there is fair comparability. I do think that when it comes to the IVAC diagnosis versus a simple VAP diagnosis, we are adding a level of complexity that should improve the ability for us to report. And I think there may be some retrospective confounding as in our data.
Thank you. At this time, I don't have any more questions in the chat box. I can ask our attendees if they have anything that they'd like answered briefly. If not, please take a minute and think about this. And if you do have more questions for Dr. Douglas, if you can send us an email at admin@henlearner.org, we'll make sure to field those questions to him or to the appropriate person. Any other questions or comments? Okay. Well, at this time, thank you, Dr. Douglas, for this webinar. It was fantastic, just as the last one was, and we're really happy to have it. And thank you for joining us to all of our attendees. We'll go ahead and close the webinar now. Thank you.